Welcome to Hibberd Health. Today I have Dr. Tess Lawrie joining me. Dr. Lawrie, thank you so much for being here today.
Thank you for inviting me.
Thank you. Dr. Lawrie has a medical degree and PhD. She grew up and studied in South Africa doing clinical medicine and research. Dr. Lawrie is the founder and director of the evidence-based medical consultancy in Bath, UK. Dr. Lawrie, what brought you to doing your in-depth and systematic review and meta-analysis of ivermectine?
Jennifer, my company does evidence synthesis routinely to support clinical practice guidelines. It's our core business. I do no industry-sponsored work at all, and all our work is for non-profit organizations. One of the most common formats of our work is performing Cochrane reviews, and Cochrane reviews underpin a number of recommendations in the NICE guidelines and WHO guidelines and clinical practice guidelines around the world. I first was aware of the issue around ivermectine and its usefulness for COVID when I saw Dr. Pierre Corey's appeal in front of the US Senate from the 8th of December. But I only saw it on the 26th of December. And when I saw it, it struck me in a couple of different ways. One was, it just struck me very odd that a doctor was having to beg in front of politicians for a medicine to heal his patients that he knew would heal his patients. Secondly, it reminded me of my work in South Africa as a doctor, because when you work in low resource settings, you're constantly aware that there are treatments that would save your patients, would help your patients ameliorate their disease, but you don't have access to them. So my heart sort of went out to Dr. Corey. I really empathized with him. I recognized that desperate doctor in him and wanting to do the best for his patients. So I thought, well, let me get the review that he's written and evaluate it. So I got the review, and I was impressed with how thorough it was. It really covers everything from mechanisms of action. It has country case studies. It had a whole lot of observational and randomized controlled trials that they'd collected, and clearly they'd been monitoring ivermectine for some time. The problem with it was that it didn't have any meta-analyses. Well, it had one small meta-analysis, but it hadn't actually pulled the data for the important outcomes. At the conclusion of the review was that ivermectine, there was evidence of a strong effect, and they called upon international agencies to devote resources to confirming these findings. But because it was just after Christmas and before New Year, I knew my experience with organizations in general is that everybody's on holiday during that time. And I thought, well, if what Dr. Corey is saying is true, then there's an urgency to this, and thousands of people are dying every day. So I can do this, I can help. So I thought, let me just do this evidence synthesis and see what it shows. So I got all the studies that they had included in their review. I assessed them all for risk of bias. So this is a routine procedure, assessing studies for risk of bias and deciding which are of too low quality and that would introduce bias. So I did this, selected 15 studies that were the higher quality out of 27 and at lower risk of bias. And I did meta-analysis for the main clinical outcomes, because the outcomes that matter to people and doctors, to the public and doctors, are clinical outcomes. The outcomes like death. Am I going to die if I get COVID and I'm in hospital and I've got mild disease or severe disease? It's how long am I going to stay in hospital? Am I going to be admitted to ICU? Will I need mechanical ventilation? That sort of stuff. And then preventing disease, you want to know, if I take this tablet, what are my chances of, and I'm a healthcare worker or I'm exposed to COVID-19, what are my chances of getting an infection, if I'm exposed? So these are the things that are important. So I extracted data from the studies on those clinical outcomes, and I was so excited with what I found. When I saw the data, I just thought I have to communicate this as soon as possible. When we pooled all those studies together, on their own, they don't look like much. When you pool them, you see that if for hospitalized patients, if you're in the ivermectine group of those studies, you had a 1.3% chance of dying if you were in hospital, which doesn't sound great. But if you're in the control group, you had an 8.3% chance of dying. So clearly, it was just so clear, and it was consistent as well. Using the statistical test that we do, there was a consistency across the studies. They were all saying the same thing. There's a certain amount of caution one would apply, and because there is a standard operating procedure for grading the evidence that you get in meta-analyses. Now, I use the operating procedure I always use, which is the WHO standard operating procedure. I evaluated the evidence according to that procedure, and it came to an assessment of moderate certainty. Now, there's also a standard way of interpreting evidence. So moderate certainty evidence means that the effect is probably, we use the word probably in the interpretation, whereas if it was low certainty, we'd say it may, and if it was high certainty, we'd say it does. So there was moderate certainty evidence that ivermectin reduced the risk of death by 80% or 83%. And the effect estimate range was 67 to 92%. So my conclusion was that it's not a question of whether ivermectin reduces deaths. It's just a question of by how much. So is it 50%, 60%, 70%, 80%? Yes. Maybe a large randomized controlled trial would be able to pinpoint exactly the percentage. But who would you get to take part in such a randomized controlled trial when the evidence of its reduction in deaths is so clear? So anyway, so there I was with this evidence, and I was just stunned, and I thought I have to communicate this as soon as possible. So this was the Sunday night. So I did that work between the 26th of December and the 3rd of January, and I just worked night and day to get that done. I thought I was just going to do that. I was going to get it to the Prime Minister's office. He was going to say, thank you, we must get ivermectin as soon as possible. And then I could get on with my usual work. It didn't happen, unfortunately. The next day, I emailed Ministers of Parliament, I emailed the Health Ministry, I emailed journals. It was just like everybody was asleep. Nobody responded to emails. And the days were moving on. So, and I was very aware that every day people were dying unnecessarily. Instead of the number of people dying that were dying, there could just be 20% of those number dying. So for every 10 people dying, there were 8 dying unnecessarily, something like that. So I started, as the days were on, because of my clinical background, I felt a huge moral duty and concern that I was kind of holding this information and not being able to get it out. So on the Thursday evening, the 7th, in fact, it was about 11 o'clock, I just thought I've got to do something. So I did that video appeal for the Prime Minister. And I'm just still waiting for a response. It's not that I've just been waiting, so I've continued to work. So what I did was then I wrote what I usually do for WHO, which is when they're trying to make a recommendation on a treatment, they hold what's called a guideline development group meeting, where I draft an evidence to decision framework, which is a standard document based on the GRADE working group, which is a Norwegian body that has these standard documents and guidance on completing them. So I did what I usually do for WHO, is I completed this evidence to decision framework. Now, they're really interesting, these frameworks, because they include, it's not just evidence on the effectiveness of a treatment. They look at other things like the values and preferences of the people who will receive the treatment and the people who will give the treatment. And they also look at the resource implications of the treatment, its costs and cost effectiveness, and they look at the equity implications, is it fair, and they look at acceptability and feasibility of the intervention. And only then is a recommendation made. So I've just been kind of operating in a sense of urgency now since the 26th of December. I invited Matt Hancock, politicians, I invited clinical specialists, I invited Pierre Corey and colleagues of his, I invited some members of the public. So I presented the evidence last Wednesday night, and in the form of an evidence to decision framework. This framework can be found on my website, by the way, which is, I think it's e-bmc.co.uk. It's a useful framework for any government to download. I wrote it for the British government, but it can be adapted for use by any government who wants to look at the big picture and to try and reach a recommendation for their country. But what was interesting at the end of the meeting, and not precipitated by me, by one of the other members of the group, was the question. The question arose, so what do we think about ongoing trials given this evidence? The best way for doctors or policymakers or anybody to figure out after looking at the evidence is to think to themselves, well, if my sister, husband, child was in hospital with severe COVID, would I want them to receive ivermectine or not? Knowing that it's a safe drug that's been around for a long time, it costs nothing, and there's good evidence that it works. And the general consensus is nobody in the room would not have wanted their sick relative friend to receive ivermectin, So, and that's how we left it after that meeting. So none of the politicians came to the meeting, and I still have had no response, not even an interest inquiry, not even a curiosity about the work that I have done.
What about local politicians, even in Bath?
I have sent emails, I have left messages on their telephones, and I've had no response.
This is a big question, and I'm in Canada, and principles of the government are not all that different. And I've tried to reach out to local, provincial, and federal government and got no feedback at all. I've had the odd journalist contact me, but not taken forward this discussion about ivermectin. And I really want to hear where you're going with this now too. I feel that it's just something now reaching out to the public, because we don't seem to be able to get the agencies to engage in dialogue regarding this.
As an aside, I would just like to say that politicians do not take a Hippocratic oath, and yet they are the ones making the decisions about what treatments doctors can and can't give. So I think as a system, as a health system, and as medical doctors, as individuals, and as the public, we need to really relook at our health systems, and because the doctors no longer seem to have control over how they treat their patients, or even access to the information that's needed, to treat their patients well. Because there's so much misinformation on ivermectin, the airways just seem to be spammed with it at the moment. The issue with ivermectin is that it's generic, so there's no money to be made off it. So there is no incentive. In fact, there's every incentive to undermine its use, sad but true, because there's just no money to be made on it. It costs, like on the WHO schedule, in a document, they have it at 3 cents a tablet. So
that's exactly what you need in order to eliminate a pandemic, is something that doesn't cost much money, that can get distributed worldwide. Tess, please tell me what your plans are moving forward, because this is definitely a big challenge, not just regarding the research, because they keep asking for more research, but what is a pathway to move forward that you see as possibly being effective, not only to get the information out there to practicing physicians, but also to the public to be accepting of this and to actually look for it and ask for it?
Well, I think, certainly the public needs to get more involved in their care as well. But in terms of my plans and next steps to get this information out there, I've put together a really great team of research scientists, and we are basically redoing the work that I did last week. We have, 2 weeks ago, we have, there are a couple more studies we can add, which should strengthen it even more. We're doing what's called a rapid Cochrane review. So As I say, Cochrane has a very well-respected methodology, and I feel that if we stick to the systematic methods that they use to distinguish quality evidence, we will be heard soon. So we are hoping to have this review submitted in 2 weeks' time, and then we've been told it will be turned around quickly. So I've made my opinion quite clear. No more placebo-controlled trials are needed. There is research that can be done. For example, you can look at different dosing schedules, and you can look at using doxycycline along with ivermectin versus ivermectin on its own. But you cannot not give ivermectin. You cannot just give a placebo, because that is unethical, because we know ivermectin works. I need to do this review to try and save some lives.
And I know it's a driving force that's almost this unmeasurable pressure to do it. Now, regarding the NIH and how they relaxed the restrictions on ivermectin, would you like to talk about that a little bit?
Yes. Well, I'm very pleased that they have relaxed the restrictions. But I did feel, reading their document, that it is very flawed with regard to the clinical evidence that they present and refer to. They don't include any of the evidence from meta-analyses, and by the time that came out, my report was published. It had already been published for 10 days. There's also this ongoing throwback to a laboratory study that showed that you needed huge doses of ivermectin. It's so absurd, it's like, oh, well, this drug can't possibly work because we have a laboratory study that shows, laboratory studies can try their best to replicate, what goes on in a human being, but it's quite likely they don't come close. And when you have such clear evidence of clinical effectiveness in human beings, not in test tubes, petri dishes, etc., it's completely secondary to figure out mechanism of action and that sort of thing. There's new data emerging from Dr. Wagstaff and colleagues, which shows that ivermectin concentrates in the lungs, which is really interesting. So there's lots of interesting new evidence which will show us how it works. But right now, that's not the priority. The priority is that it does work. There's a good meta-analysis done by me, which shows that it works to prevent deaths, it works to improve outcomes and reduce the length of the sickness and the length of you being PCR positive, COVID positive on test. And if you're a health worker or a frontline worker and you're exposed to COVID, it reduces your chance of getting COVID by 90%. So I don't know how they could miss that.
Yeah, that's amazing. Now, but the fact that they even did release restrictions, I guess, is most definitely is a positive. But
Yes.
where do you think it's going to go from here? Any idea? NIH is a highly revered agency. Australia, England, and Canada and the US all seem to be following a very similar pathway regarding restrictions or loosening of restrictions compared to the rest of the world.
Mm. There definitely are. There are countries that have already implemented ivermectin. India's been using it. States and India have been using it since August, and countries in South America and so on. And doctors in nursing homes have been noticing the improvements in patients they've been treating for scabies. They've been seeing, well, this bunch of elderly residents haven't got COVID, and I've been treating them with ivermectin for scabies. So there's lots of evidence from all sorts of different studies, but there's this obsession with large, expensive, randomized trials managed by high-income country management, and disparaging attitude towards the wonderful research that has been conducted in low and middle income countries. But I know how difficult it is to conduct research in low resource settings, and I just take my hat off to these clinicians who've found the time in their busy schedules to also conduct a study and to write it up and to submit it and get that far, because it's so difficult. And they've done it they've self-funded and they have no conflicts of interest. They've done it out of the love of their patients and of humanity, and I'm very grateful to them for doing the work.
That's really wonderful.
I'd just like to say I feel very blessed to have this information to share.
And thank you so much for spending the time to talk with me today and share your information with everybody that's listening. And please subscribe to my YouTube channel, Hibberd Health, so you can follow discussions as they get uploaded on an ongoing basis. Thanks very much.